Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled Health Professions Regulation in the U.S., and it was presented by Jean Moore and Elizabeth Carter on March 12, 2014.
At this point in time, I want to go ahead and introduce to you our two presenters. Jean Moore has served as the director of the Center for Health Workforce Studies located at the University of Albany School of Public Health since 2004. She brings over 30 years of experience in health workforce program administration, policy development, and research. Dr. Moore's research is focused on a wide array of health professions and on health professions education, including graduate medical education. Elizabeth Carter is the Executive Director of the Virginia Board of Health Professions. She has held this post since 2001, and before that, she was the Deputy Executive Director. Dr. Carter also heads the Department of Health Professions Healthcare Workforce Data Center, instituted in 2008. Her responsibilities include overseeing policy research and advising on issues pertaining to the regulation of health professions, the healthcare workforce, strategic planning, and agency operations. After the presentation, there will be time for a Q&A session. To ask questions of our presenters, use the chat panel on the right of your screen. And make sure you send the questions to all panelists to ensure that they have an opportunity to be answered. And after the event ends, you will be directed to a short evaluation survey. So please take a few moments to fill it out and provide us with your feedback. Jean?
Thank you. So today's presentation, first I want to provide some context. I'd like to briefly describe the changing healthcare delivery system and the implications for scope of practice rules. And next, talk about state-based health professions regulation and the issues associated with this approach. And then review potential strategies to strengthen scope of practice decision-making. And finally, we'll have the opportunity to hear about a best practice, Virginia's Board of Health Professions, which will be presented by Dr. Elizabeth Carter. So clearly, health reform is changing the healthcare landscape, and I think that, we fail to realize that it's broader than just federal reform. So we know about the Affordable Care Act and the efforts to expand access to basic healthcare services, contain costs, improve quality. Many states are looking at Medicaid reform, and again, with similar themes of expanded access, improved quality, lower costs, better outcomes. Private insurers as well are stepping up to the plate, and again, with some very consistent issues that they want addressed. So what changes with health reform? There's a shift in focus for the healthcare delivery system away from acute care and to primary and preventive care, with an emphasis on effective management of chronic diseases and payment reform, moving away from fee-for-service and toward managed care arrangements, with incentives for keeping people healthy and penalties for poor outcomes, including inappropriate hospital readmissions. Health reform is supporting new models of service delivery, accountable care organizations, health homes, patient-centered medical homes, all are and these new systems of care are increasingly using team-based approaches. And teams may include physicians, nurse practitioners, physician assistants, registered nurses, social workers, licensed practical nurses, medical assistants, care coordinators, community health workers, among others. And team compositions and roles vary depending on the patient population. Another important point is that multidisciplinary teams are associated with positive impacts on patient outcomes. I think that in healthcare there are a lot of team approaches But when I talk about it in this context, I'm specifically referring to teams comprised of multiple healthcare professionals with a collective identity and shared responsibility who work collaboratively to deliver patient-centered care. And the research suggests that healthcare teams with greater cohesiveness and collaboration are associated with higher levels of patient satisfaction and better clinical outcomes. The most effective and efficient teams demonstrate a substantial amount of shared responsibility or scope overlap. So this all sounds great. So what's the problem? One important problem is that we face shortages or, in some instances, a maldistribution of primary care practitioners. Another important issue is that it's not clear that we train students in team-based models of care, or that we're training for emerging functions like care coordination, health coaching, or just information about population health. Another important issue is scope of practice restrictions. Health professionals are not always allowed to do what they are trained and competent to do, and the scope overlap needed for effective team-based care can be challenging to achieve. And this is going to be the focus of our discussion today. Interest in scope of practice regulation is increasing. The National Council of State Legislatures report that between January of 2011 and December of 2012, 1,800 Practice Act-related bills were introduced in state legislatures, and about 20% were adopted. There are many factors that are driving scope of practice change. The first one, the changing public policy, we've already discussed. Another important one is lack of access to needed health services. Demographic changes, including population aging, growing diversity, and also racial ethnic disparities. Cost pressures in healthcare. Providers, I think, are increasingly faced with the issue of doing more with less. Technology. One important example, technology example with scope of practice implications is telehealth. Another, consumer demand for alternative providers, such as acupuncturists, and market forces. A good example of that is the growth in retail clinics. I think there's growing recognition that scope of practice rules impact cost, quality, and access to care. In the U.S., states are primarily responsible for regulating health professions. And what this means specifically is that for specific health professions, states regulate things like required education and training, licensure, supervision. They'll define the regulatory board and the membership of that board, the disciplinary process, and scope of practice. So before we go any further, I think it's important to understand what we mean by scope of practice. And it's important to differentiate between professional scope of practice and legal scope of practice. Professional scope of practice is also known as professional competence, and it describes the services that a health professional is trained and competent to perform. A number of professions have what's called model practice acts. A couple of examples: physical therapy, social work, pharmacy. And in those model practice acts is really where you find professional competence, what these professionals have been trained and are competent to do. Legal scope of practice, on the other hand, is based on state-specific practice acts and define what services a health professional can and cannot provide under what conditions in that state. Legal scope of practice and professional competence overlap, as you can imagine, but the amount of overlap varies by state and by profession. So what are some of the key issues associated with state-based health profession regulation? First, there are mismatches between professional competence and state-specific legal scopes of practice. Sometimes legal scopes of practice are very restrictive and not consistent with what people are capable of doing. So when someone talks about working to the top of their license, in some states, if licensure rules are restrictive, it may not get them very far. Another issue is lack of uniformity in legal scope of practice across states for some health professions. So some states don't license some health professions at all. There's resistance to allowing scope of practice overlap among health professions, which is really critical for team-based care and shared responsibility. And that is in part because the process for changing state-specific scope of practice rules is at times slow and adversarial. So I want to look at each of these individually. And we'll start with the mismatch between professional competence and legal scopes of practice. So health reform programs, as I mentioned, really depend on health professionals practicing to their full level of competence. If state-specific scopes of practice have not kept pace, then it doesn't reflect professional competence. And these changes can constrain a health professional's practice and impact cost, quality, and access to care. One example that I think we hear a lot about and that I want to cover in this presentation is nurse practitioner scope of practice. So what you're seeing is something that depicts state-to-state variation for nurse practitioners in a number of key areas. Some of them are very detailed, like signing death certificates, and some are very broad, like independent prescribing. But what this illustrates is the difference in scope of practice for NPs by state and by region. This state wheel, as we call it, is on the Barton Associates website. And the one on the website is actually interactive, and you can roll over specific states for more details. So if this is of interest to you, I encourage you to look it over. If we look at it a different way, we see that variability in nurse practitioner supervision requirements are really critical. So a third of states give NPs full practice authority, 2/3 put restrictions on NP practice, and most relate to the issue of physician collaboration and supervision. I suppose the silver lining in this cloud is that the scope variation actually supports comparative effectiveness workforce research. And I want to talk about a couple of research studies that were recently released. Trzynski and colleagues actually looks at a before and after in a state, looking at what happened in a state before scope of practice for nurse practitioners was expanded, and then after. And then Joanne Spetz and colleagues looked at retail clinics across states with different scopes of practice for nurse practitioners. So I'm not going to go into full detail on findings, but the bottom line is that states where scope of practice for nurse practitioners was least restrictive, NPs in those states were able to see more patients, improve outcomes, and provide more cost-effective care. Another issue is that some health professions are not recognized at all in some states. So one example is certified registered nurse anesthetists, or CRNAs. In New York, while CRNAs are authorized providers of anesthesia services, their scope of practice is not defined in state law. And despite that, they're an important provider of anesthesia services, particularly in rural areas of the state. And their ability to practice in the state is actually drawn from CMS rules. But because they're not a recognized provider in the state, they can't directly bill the state's Medicaid program, and they must be supervised by a physician. In Colorado, on the other hand, CRNAs have a defined scope of practice in state law that allows them to practice in a fairly autonomous way. Resistance to scope overlap. Scope overlap would be more common if there was greater recognition that different health professionals can be safely trained to perform the same tasks as other health professionals. Pharmacists providing immunizations is a really great example. So historically, the administration of immunizations were limited to physicians and nurses, and it was broadened to include pharmacists. But it took over a decade, from 1994 to 2009, and again, taking it state by state, to allow pharmacists to give immunizations. Scope overlap is even more problematic when it involves delegation. For example, physicians and RNs are legally responsible for services provided by others they supervise, including medical assistants, LPNs, community health workers, and there are issues with liability that often arise when these issues are looked at. Another example of scope overlap is seen in emerging workforce models, such as dental therapists. So dental therapists are a new type of oral health professional who provide basic restorative dental services. They're currently authorized in Alaska and Minnesota. And Minnesota, by the way, has a couple of different approaches to this. One is dental therapist, and one is someone with a dental hygiene background who is considered an advanced dental therapist. But primarily their services are targeted to underserved populations, and early evaluations of the model are promising. There are a number of versions of this under consideration in a lot of other states. But it actually gets problematic when service providers cross state lines. So, for example, we knew of a provider based in both Minnesota and North Dakota that could use dental therapists in one state but not the other, despite the fact that need for basic oral health services was pretty great in both states. Changes to state scope of practice requirements tend to be slow and adversarial, often costly, a turf war between two groups with unequal resources. Typically an incumbent profession overpowers an emerging profession, and frankly it contributes to animosity between professionals expected to work together, making team-based practice models harder to implement. And I think it's important to recognize that professional self-interest tends to drive this. So what can we do about it? What are some strategies that we can think about to strengthen both the content and process of scope of practice decision-making? One important thing we can do is align profession-specific state scopes of practice with professional competence for all health professions. And again, one good, easy way to do it, maybe not easy, but one good way to do it would be to look at model practice acts and compare how a state-specific scope of practice compares to the Model Practice Act. Another strategy, and an important one, is to increase the engagement of consumers in scope of practice decision-making. I think there's general agreement that we need to base decisions on what is best for patients, not what is best for professions. So I will tell you that Ontario, Canada, instituted health professions regulatory reform and greatly increased the consumer input into these decisions. And right now, 40 to 50% of regulatory boards in Ontario are comprised of consumers. Another important thing is to ensure regulatory flexibility to accommodate emerging roles and scope overlap. I think that the state-specific health professions regulatory system is probably not well suited for the sort of flexibility needed to support changing roles for health professionals. A really good example is in dental hygiene, that there's increasing recognition that dental hygienists working in safety net settings and school-based clinics and nursing homes can really contribute greatly to improved access to preventive oral health services, but it's really difficult achieving the autonomy needed to allow dental hygienists to work in these settings. Use the best available evidence in scope of practice decision-making based on what is in the best interest of patients. Again, I would reiterate that it needs to be research and not advocacy. And when evidence is not available, allow time-limited demonstration or pilot programs with comprehensive evaluations. And I can point to the fact that California has had a Health Workforce Pilot Projects program for many years and has created opportunities to make mindful changes in scope of practice rules using that. Create a state oversight committee to review all proposals to change scope of practice or to create new categories of workers. Clearly, as I've been suggesting, we need to broaden the dialogue on scope of practice decision-making. And we will actually hear a really excellent example of this. My colleague from Virginia will talk about a best practice in her state related to health professions regulation. And finally, establish a national clearinghouse on scope of practice information and research. I think it would be great to create a place for one-stop shopping for up-to-date and reliable information on scope of practice proposals, modifications, demonstrations, innovations, evaluations, model practice acts. And I'm pleased to report that the Health Workforce TA Center is actually developing a web page on its website devoted to scope of practice. Now, this is not a national clearinghouse by any means, but we think it's a really important start to begin to put information on this very important topic in one place and create access to it. We hope to have that web page up in the next 2 weeks. So now we're going to hear from my colleague Elizabeth Carter in Virginia to talk about, again, a best practice, a really exemplary example of strategies for improving scope of practice decision-making.
Okay. Thank you. Thank you, Jean, and all of you. It's very nice of you to invite me to speak to this. She makes me feel a little bit a trepidation at us being a best practices state because we've been doing this for so long. But let me just walk you through exactly what Virginia has in place and kind of give you a little bit of the background of the history of it. You move to there. Turf battles, scope of practice issues have been around as long as the professions have. And one of the things that Virginia did back in the 1970s was to pull together all of our health regulatory licensing boards under one roof. And so it's the Department of Health Professions. And as part of that creation also came about was the creation of the Board of Health Professions itself. And if you see on the slide, there's lots of different sections of code that had to be amended to create this. But in essence, what it's enabled us to do, because we're all together, if you will, all the licensing boards are here, we have members on our Board of Health Professions from each of the licensing boards. There are 18 members, there are 13 boards, and you see a listing of all of them down at the bottom. And you also have 5 citizen members. It's very important to have those citizen members included. I think prior to that, we didn't have a lot of citizen member participation in a lot of the boards, but this was a big sort of historic moment in Virginia to make sure we included that insight. And each of them is appointed by the governor. And another thing I think that's very important for everybody to consider here is that each member's vote on any matter that we're reviewing carries the same weight as another. So, for example, medicine's vote doesn't mean any more than a citizen member's. And the majority carries the vote, and all of our meetings are public. They're absolutely public. Anyone can come to them. We have members of the public who can solicit studies. It's a wide open door. Just to kind of give you just a little bit of briefing for Board of Health Professionals' powers and duties, they are quite varied. As indicated before, we look at strategic planning issues, agency operations. We look at the agency's budget, and another piece of this is evaluating the need for coordination among those health regulatory boards that I mentioned earlier. One of the key factors, I guess, that brought us here today was examining scope of practice conflicts involving both regulated and unregulated professions, and we're supposed to advise those regulatory boards, our director, our General Assembly, governor, and so forth, on the nature and degree of such conflicts. So, and I'll speak a little bit more about how we go about doing that. Oh, I'm sorry, Jean, would you move me to the next slide? I'm sorry. Jean, I can't push the button. You can have to do it for me. Thank you. I'm so sorry. Okay, we'll come back to that. Let people review that for a second. As I indicated before, we do have the ability to look at scope of practice conflicts. We also evaluate healthcare professions those that are currently regulated and not, to consider whether each should be regulated and the degree of regulation. Now, when the board itself determines that there's a need for the public best interest to be served by regulating a group, we'll recommend to the General Assembly and the governor a whole regulatory system to establish the appropriate degree of regulation. Sometimes we actually recreate boards, restructure them, and that sort of thing, and these are our sunrise reviews. From that work, again, back in the 1970s is when we started. If you'll flip to the next slide, Jean, we're going to go to the criteria. The criteria, there's a whole manual that you see listed down on that website at the bottom there that walks you through. There's a full sort of methodological approach that we take to this. It's grounded in the Constitution. It's grounded in an understanding that people have a right to practice professions without, as long as they're not hurting anybody, that kind of thing. But we also we actually have specific definitions for what we mean by risk of harm to the consumer, the specialized skills and training involved, what we mean by autonomous practice, and there's that scope of practice. There's a full definition for each of those, and economic impact, alternatives regulation, and least restrictive regulations. So flip to the next one, please. As Jean has indicated, we've been looking at a lot of scope of practice disputes and team delivery model development, all sort of in the wake of, the Patient Protection and Affordability Care Act, just the need for, we have a growing and aging population, and also our practitioners are aging. Lots of things are changing right now just to meet the demand for health care. And so as part of our Secretary of Health and Human Resources in Virginia, he requested the assistance of the Board of Health Professions back in 2011. And he just kind of left it open. He said, help us with this health reform issue. And what the board decided to do was to begin to engage in a series of reviews into the potential barriers to effective team delivery that's posed by the scope of practice restrictions that existed at the time. Since that time, we've done a review for nurse practitioner, for pharmacist, pharmacy technician is underway right now, almost finished, dental hygienist, and dental assistant. As we were moving through those reviews, as you can imagine, there's lots of other negotiations going on at the General Assembly with the professions themselves, and that's fine. It all worked out quite well. Since the beginning of the reviews, we've had collaborative practice legislation enacted both for the nurse practitioners and the pharmacists, and it definitely is that collaborative approach. They're not as free maybe as they are in other states. I know if you look back at the wheel that Jean had on there of the different states and where they are for nurse practitioners, but it's light years ahead of what it was previously. We can't take the full credit. I mean, obviously, the other negotiations were going on, but one thing that the Board of Health Professions is able to do, because again, the perspectives are informed perspectives. The staff here we do as objective research as possible, but we also have, those citizen members and members of each of the professions to speak to the issues. So what we have, instead of getting a white paper from one professional organization versus another, you have an independent assessment of the facts that we can attain at the time of the review, and we do look at those patient care issues. That's our first thing that we look at. When we're talking about expanding any particular profession, we need to make sure is there evidence of harm in other states where they've been expanded, and what kind of, and it really goes into a lot of detail I won't go into here, but I'll be available certainly anytime anybody likes to talk to me after the presentation today. And that's pretty much what we have for this right now, and I'll turn it back over to Jean.
So now we are open for questions.
Yes, thank you both. That was great. So we'll go ahead and start the Q&A session at this point in time. Once more, you may ask questions using the chat panel on your screen, and please make sure you direct your questions to all panelists.
Okay. I see Katie has a question about, how do we determine collaborative practice? It really is the devil of the details, and those are the things that did get worked through in legislation. What we did basically was to remove a lot of the supervisory requirements. For example, initially for nurse practitioners, in order for them to write a prescription, they could write a prescription, but somebody had to come back and actually look, or the physician had to come back and look at the prescription and say, oh, that's okay. That's no longer the case. There's a less, the same kind of review also for the pharmacist. There's a lot more freedom for the pharmacist to talk not only to the particular prescriber, because we know that there are group practices out there. They now can speak to someone from the group if they need to modify a patient's prescription, for example. That's the kind of thing. But you'll have to really look at the details of each piece of legislation to get what we mean by collaborative practice. But that theme, though, you can see it for both of those professions is pretty profound.
Hey, good answer. Next question. What is the best strategy for aligning profession-specific scope of practice with professional competence?
So I think that one of the issues, and actually I was sneaking a peek at some of the questions that are coming in, and one talked about some of the variation that we see state to state on NPs may in fact be related to the need to standardize education and training requirements. And again, I think a good shortcut is to look at model practice acts and say, okay, how closely does my state compare to what's my state scope of practice compared to the Model Practice Act. But the other piece to this, and I agree completely, is that education and training programs need to meet certain standards, and that should be part of the accreditation requirements, so that, in fact, a nurse practitioner who is trained in Indiana versus Florida comes out with the same set of basic knowledge and skills and capable of meeting the requirements of the Model Practice Act. And in discussions with AACN and other organizations, I know that there is clearly an effort to make sure that all of the APRNs are moving in a very consistent direction to that end.
Okay. Okay, next question. Could the presenter talk about medical assistants, the extent to which states have not delineated their roles, especially as they're taking on increasingly larger roles with more teamwork?
So, actually, medical assistance is one of those categories of workers that, we talk about inconsistency in regulation across states, and unfortunately, that is one of them. And many times, what they can and can't do will fall under the task delegation of another a professional that they will be working under the supervision of. It makes it a bit more complicated and makes that variation even less visible. But, again, I know that as we move to team-based models of care and, the primary care team says, gee, why can't the medical assistant give a flu shot? I mean, those are the issues we have to grapple with, and to ask ourselves, what would it take to make sure that that happens safely and effectively and under appropriate supervision? But medical assistants clearly play an important role in the delivery of care today, and again, we don't have as much information about that.
Okay. Can you speak to the best practices of the California pilot program? How are pilots chosen? Are there funds for scale-up?
Unfortunately, I don't have that level of detail, but I will be providing a link to the California website about what they've done. And again, my sense is that this has been a very systematic and to some extent successful approach to looking at modifications to scope of practice and allowing the testing and careful evaluation of different approaches. But when we put up our scope of practice information on the TA Center, there will be a link to that program and exactly what they do.
Okay. Liz, I believe this one's for you. Can you give us an example of a citizen appointment on the Virginia Board of Health?
It's the Board of Health Professions. Yes. These are members that are, they actually ask them for themselves to be considered by the governor. So they can represent consumer groups, they can be just individuals, they can be members of, we've had former judges, we've had just a wide variety of people that have been on our boards, but that's something that is decided by the governor himself based upon their application and their choice just to serve on the board. It's an open door.
Okay. Here's another question. The Virginia team-based care requirements appears to be inconsistent with the patient choice and competition recommendations of the recent FTC statement. What plans does Virginia have to address these anti-competitive statutes?
And I'm not sure what the individual is asking about. I'm not sure what the Virginia team-based care requirements is. I'm not sure what they're referring to. That's not something that's gotten to my level anyway.
Okay.
So it sounds like we would need more information to be able to respond to that question.
Well, that's one we might be able to get back to later on and post it to our website. How about this one? Have you seen or do you anticipate any increase in malpractice claims or disciplinary activity by state boards relating to increase in scope of practice?
You know, that's a really interesting question, and Liz, I will certainly defer to you on your experience with this, but I think that's one of the things that sort of drives the concern about making these adjustments. And again, my sense is that if people aren't practicing to the full extent that they're capable of, my thought would be they should be able to do what they've been trained to do, and of course we always monitor safety. But I also think that the issue, particularly under delegation authority, is very, very important, that we consider what the issues are related to the supervision of someone who's performing tasks that you're presumably overseeing. So I do think it's an important issue, and I think that as we move forward in the discussion with scope of practice, we need to look at what others have done. Liz, have you had any experience with that?
When we were doing the nurse practitioner review initially, we were looking at what other states had done, and we did pull, actually we were able to get the malpractice information. And for those that over time where you saw the expansion, honestly there was nothing to prove that they were having any higher level of malpractice being brought against them. So, you know, I'll be quite honest with you, I've not looked at it since 2012, but, you know, I guess we'll always have to be monitoring that sort of thing. But when we were first looking at it, and other states had done it, there was no expansion of any kind of malpractice suits. Of course, we do have a litigious society, and I guess once people figure out they can sue, they may choose to do so. But right now, it seems to be we're not finding that level of concern that I think that was originally brought forth by some of those that were opposing nurse practitioner expansion.
Okay, next question. Do you have any comment about the fact that for nursing there are multiple accreditors rather than one accreditor as there are for other professions?
So I'm not sure what accreditor means. I know that, say, in the case of NPs, there are different certifying organizations depending on the specialty that is that a nurse practitioner is pursuing. And again, I will say that AACN, in collaboration with others, is working to create some consistency in that approach, so that when, again, and I think it's beyond just NPs, but APRNs as a whole, that there are some consistent approaches to the certification of advanced practice registered nurses.
Okay. Have you seen any changes in hospital credentialing related to increase in scope of practice trend?
Liz, any comments on that?
Nothing that I'm fully aware of yet. I know that there's activity out there that's going on within our hospital systems to hire more physicians. We know that they're actually becoming employees of the hospital systems. It seems to be that's the trend that's moving in that direction. We're also, here's something else. We know that retail clinics across the country now, particularly like your Walgreens, your CVS's, they're moving toward hiring a lot of different professionals besides pharmacists. So I actually saw a job announcement not long ago for physical therapists. So those minute clinics and urgent care kinds of places are moving into that primary care even a little bit more. I guess if they're bringing in physical therapists, maybe a little bit more of the chronic disease state management. I know that the pharmacists are doing that. So I think you're getting lots of different organizational changes, I think, and the retail clinic piece of it is the biggest. And the hospitals, I know they're involved in it as well, but there's a lot going on at that pharmacy corporate level that's going to change the face of healthcare delivery. It's happening as we speak.
You know, one of the things when you mention retail clinics and pharmacy approaches, I mean, I think that those models are perfect for integration into an accountable care organization because they can create access where it typically isn't available. And again, finding the workforce to provide the services at a retail clinic is really important. And again, I think that scope of practice issues could be problematic depending on the state and what some of the primary care practitioners are and aren't allowed to do.
Okay, next question. How did Virginia pass its original Model Practice Act in the 1970s based on organized medicine's opposition? How can other states today get such a process knowing that there will be strong medical opposition?
Well, we're not going to pick on the physicians a lot. I don't think don't be mean. That's not nice. One of the things I think we've been very successful in Virginia being able to do is to look at the benefits that come from pulling together the way we have. We've been able to say, one thing you can say is you save money. We share so many of our administrative functions, so we get economies of scale. We get investigative staff that can be applied to all kinds of different professions, cases, and so forth. I mean, we ended up finding by our own experiences in it working, gradually over time. I wasn't around. I know I'm old, but I wasn't around in 1977, so I don't know all of the battles that took place. But I think we're here now. I mean, had it been a tremendously adversarial kind of environment, even between now and then, we wouldn't be here, but we are. And we have good support from all of our boards, the professional associations, at this point, I mean, I think it's accepted here. So what other states may do, I mean, I'll be happy to talk with you about what your particular circumstances are. I know most states, with the exception of, say, Washington State and Utah and a few others, I think Minnesota has sort of an umbrella organization. Many of you are they're individual boards that are in individual offices, and that's always the toughest. But I think, you know, with economic times the way they are, it make sense to start to pull that together just for reasons of administrative support, and then you work from there.
You know, one of the things I want to point out is I know that the regulatory reform in Ontario, Canada, was precipitated by a really terrible circumstance that a particular physician was actually accused of terminating the lives of some of his patients. And there was a sense that the system in place for regulating health professions was not working. And that's what precipitated change. And again, some of the reforms, I think, were designed to address, you know, the sort of scrutiny needed to keep something terrible like that from happening again. But it actually created a more reasonable approach to regulating health professions. And again, one of the issues that I think is most important is the opportunity to broaden the dialogue, the opportunity for consumer input, and the opportunity to take scope of practice discussions out of the hands of a couple of professions and create a more mindful dialogue about implications.
Okay. I'm sorry, I want to follow up on that. We also have in Virginia what's called a Joint Legislative Audit and Review Commission, and they were involved. One of my staff people reminded me of that. They were involved in the original review of the issue as well, so I'm sure the buy-in and the recommendation from the General Assembly members and their staff had something to do with this as well. So you have to, there's a lot of stakeholder involvement in this.
Okay, next question. Certain universities across the nation offer NPs postgraduate residency training programs, especially in areas such as primary care and critical care. What are your thoughts regarding standardizing these programs as a requirement?
So I'm probably not in the best position to say that's a great idea or a bad idea, but I guess my first thought would be, well, you know, is there a concern that the amount of clinical time in NP training is not sufficient, and this creates some better approach to making sure that they're well prepared for their first practice opportunities? So, you know, while I certainly wouldn't oppose it, I think perhaps one of the issues could be where would it happen? Could it affect opportunities for clinical placements for other students? And where are the resources to support it? So again, I guess for me, it's an interesting idea and could certainly create better experiences, but I just don't, I think it would be important to better understand those issues, and unfortunately, I'm not one who can respond to all of those questions.
Nor I.
Okay. Are national certification exams or training curriculum seen as better methods to address competency measures?
You know, it's really interesting. The issue of how one tests competencies and whether they actually have to be demonstrated or tested for, and how one sort of embeds that. I actually had some discussion around this with PA and NP associations, and you know, the general sense was that for the case of NPs, that any of that sort of clinical, you know, demonstration of clinical competence is done in the training program itself, whereas the certification is more of an exam to test knowledge and not any sort of skills testing. And I think that there's a lot of interest in the idea of whether that should go further or not. And again, I've only had some very, very limited discussions with people about that, but I do know that, you know, again, it's an issue of how do we assure that we are producing well-prepared and safe practitioners. What are some of the approaches that we ought to think about using, whether that be a residency or advanced training or, you know, standard, you know, clinical competence testing. Again, I think that, you know, at least for me, I think the jury is still out, but I think it's an important topic and merits further study.
Jean, yeah, this is an ongoing issue for all professions to figure out how much of your determination of, and it's got to be minimal competency. Just make sure that everybody understands that state licensing boards are only authorized to ensure that the practitioner is minimally competent. So if they can just, I mean, minimally, and I hate to say it that way, but that's what we have to ensure. The floor has to be assured because people have a right to pursue their life, liberty, you know, property, and all of that. But the whole issue of figuring out, you know, how do you assess that competency? Every profession goes through this, and they've moved really over the last couple of decades toward a national psychometric experts being involved in helping you with it much more. But I mean, it's not something that's a one and done. Every single year, almost all the professions have someone come in and talk about, you know, how are we assessing where we are? What do we need to be to make sure that we ensure the public safety without overly burdening the people that are trying to come through the schools and obtain a license. So it's as Jean indicated, it's ongoing, and and we're in the midst of you know, health reform and everybody being asked to do so many more things than they used to. I think it's a challenge.
And, you know, Liz, one of the other issues for me is that, you know, I wonder about strategies for using electronic health records to pay closer attention to outcomes, because if we do this properly, we could have a better understanding of who's providing what sorts of services to the patient, and we can look at outcomes so that there may be a better way to really judge the effectiveness of our current approaches in terms of providing safe, high-quality care and good outcomes.
Right. And I think to date what you have are individual, you know, studies that have been done for different team delivery approaches, but everything is in such process right now, I don't think we have anything definitive. So you're right. It needs to be an ongoing review of those, using those records to try to figure out what will work. But it may be different everywhere. So I think it's more complicated than any of us can think about at this point. It's just there's so many activities going on and so many changes are underway.
Okay, I think we can get in one more question. Regarding the suggestion for a state oversight committee, do you have any thoughts for keeping these committees from being dominated by the older professions who are fighting scope of practice expansions?
Well, again, I want to kind of stick with Liz's point about, you know, there's no good guys, bad guys here, but I think that one of the really important strategies is broadening the dialogue. And I will tell you that in New York, we had been contemplating putting together this sort of committee to be able to look at scope of practice issues. And, you know, we said, well, okay, who would be on this committee? And again, you know, clearly you have to involve the professional boards who, you know, clearly have to weigh in on, you know, impacts of these changes. But again, it was broaden it. Let's include consumers. Let's include provider associations. Let's include, you know, affected state agencies. Let's, you know, let's make sure to have a broader conversation about what is being proposed and what the implications are. And again, one of the things we had talked about was, you know, to look at the best available evidence. Is, you know, is any of this being done somewhere else in the country? And if it is, what do we know about it? And if it's not, is is there the potential to develop a demonstration program that is carefully evaluated so we can better understand what the outcomes of these approaches are. So, you know, I think it really requires sort of an understanding, you know, the circumstances in your specific state and building the collaborations you need that create some dialogue that's just broader than what we seem to have right now.
Right. I do want to add one thing too, Gina. I kind of flipped over it very quickly when I was speaking, but one of the, and it's the soft approach, if you will. Our board is an advisory board. We cannot make the General Assembly do anything. We can't make the professions do anything. But what we do provide, and again, we have the long history of doing, is the objectivity. And so that's what's respected. But again, it's not, you're not going to force any one group to do something that they don't want to do. But our job is to objectively advise. And I think that's where you start. You start with your good, your gravitas from an objective standpoint, and hopefully that'll benefit everybody.
Okay, I think we're going to try and squeeze in one more question. It would seem that the need for and issues around scope of practice and available healthcare workforce play out very differently in rural communities versus urban communities. Is that your experience, and how might that be handled? In some of our rural counties, the role of nurse practitioners, for instance, is much more critical than in urban areas, which are often more crowded in terms of available health professions. Thoughts?
Well, I think this is an incredibly important question or point. I think that how we deal with rural areas is extremely important, and it may be somewhat different. So, for example, I'm aware that in some rural communities, the emergency medical services workforce are playing really important roles, and in some ways almost operating like community health workers or care coordinators. So, you know, I would say it's not just kind of the higher end of the scale, but it's also who's on the team and what sorts of things can people be allowed to do, and you know, understanding the issue of you know, the rural areas clearly suffer from shortages, the fact that healthcare professionals tend to distribute themselves more in urban areas. Is really critically important points. And again, I would say if we were thinking about demonstrations and we understand that issues are perhaps more problematic in some parts of a state than others, I mean, maybe that's the prime place to test out some of the things we know are going on in other parts of the country to see if it actually can address some of the unmet needs of rural populations.
Okay. Liz, do you have any follow-up?
No, I agree with Gene on that, and I think in Virginia we've done some pilot work with the oral health issues in rural areas, because that is tremendously bad issue for us, and we've actually created a dental technician 2 position to provide services, for the prophylactic kind of services that have just been lacking so badly. But I agree with her. I think the pilot approach is the way we need to, all the states probably should consider addressing the rural health issues. But, you know, once you establish that they're safe for those folks, then I think the next step is to move it to a broader part of your state.
Okay, Gene, Liz, I thought that was terrific. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.